Okay. Did everybody get their application done? Anybody still needs a little time? Anybody out there?
I finished my application.
So did I. I'm finished.
Great. Anybody have any questions or concerns or hangups with it at all?
It told me that my address didn't exist, but I'm 100% sure that I typed it incorrectly, so I just continued anyway.
Okay, that's interesting. I've had that situation where I've tried to ship something and it says, is this your address? And it's like, no, that's not my address. But that's interesting. Well, keep that in mind because, you know, most things are done remotely, but these days, but they're still going to try and send things to you. And if they send it to that address and it gets there, then that's not a problem, I guess. So that's a new one. Anyone else? It's helpful to hear about anything like that address issue so that, you know, if in the future students have problems or concerns, we can address them.
I just had a quick question about the verification request submitted. How long would that take?
How long? Say again?
So basically, course completion and practical skills verification. This is verification request submitted. How long would we get that back? How long would it take?
So again, mostly it's on my end for the verification in that I need to sort through the stacks of paper on my desk and stuff and update everybody's grades in Canvas. And once you are enrolled in EMT 111 and once you've paid, then if I determine that you've met all the course requirements, then I will submit a list to Dr. Gould. Once I've done that, his track record with turning around the verifications is 24 to 48 hours. And so you will then, the last thing you'll probably hear from me for this semester is an email saying, I've submitted the first round of verifications. And then if there's some reason I can't verify certain people, I will email them individually. But when I say that that round of verifications go out, you should start checking your candidate status every day until you see that verification has been completed. If I get an email back from Dr. Gould saying, hey, I verified everybody except this dude, Reco somebody, he's not in the system, then I'll let you know, and you're going to have to, it's going to be between you and the National Registry, most likely, to figure out what the issue is. Does that make sense?
Yes, sir. Thank you.
All right. Oh, it was Rodriguez. Sorry.
Yes.
I'm too used to giving Ruiz flack for whatever, for no good reason usually. But what else? Anyone else? So if you go to the National Registry's website, and since I'm back online, let's see if we can share that. There's a page that talks about the cognitive exams. So the cognitive exams cover all the topics you've been tested on, FISDAP and what have you, the academic didactic stuff that we covered in lecture and lab. And that is going to be the exam that you're going to be doing online or in person with Pearson. being the host. Amador, are you there?
Yes, I'm
You
here.
see the screen?
Yep.
Alrighty, excellent. So this is the page that talks about the cognitive exams, and it basically gives a lot of information, more than you're going to probably want, about how they create the exams and what they use to verify the exams. And so the exam itself is based on a practice analysis that researchers at the National Registry do. And they actually find out what are the most common things that EMTs do in the field, what knowledge is most useful, or what knowledge establishes competency. And they create test questions and they pilot those test questions. And they pilot those test questions on exams. So the first thing that you need to know about the National Registry exam is that somebody might go to the exam and they might have, X number of questions, and you might have Y number of questions. And if you're there for 75 questions and the exam shuts off, that doesn't mean you passed or failed. If you're there for 112 questions before the exam shut off, that doesn't mean that you passed or failed at all. In fact, the computer adaptive test has an algorithm that gives the candidate questions of varying difficulties, easy, moderate, or hard, and it does them fairly randomly on all the 6 topics that we've been dealing with in the last semester. So because you got what seemed like a difficult trauma question, and then you got another difficult trauma question, and then for 5 questions you didn't get any trauma questions, or 10 questions or 15 questions, no more trauma questions, that doesn't mean you passed trauma, and it doesn't mean you failed trauma. There's no way to know in the middle of the exam what the algorithm is doing and why. Plus, because some people would walk out of there after taking 25 questions or 30 questions and go, oh my God, I failed the exam. There's no way I finished the National Registry exam in 26 questions or whatever. They actually created a floor. They actually give you a minimum of 75 questions. And part of the reason why they give you a minimum of 75 questions is because of these pilot questions. They are using, just like with FISDAP, there are questions in there that probably nobody gets right because they are piloting those questions. And if you take the EMT National Registry exam, there's going to be at least 10 questions that are pilot questions. They don't look any different or read any different or behave any differently than regular questions, but they may not have a correct answer. They may be testing the stem, the body of the question. They may be testing one of the answers or whatever to see what people choose and gather that data to decide whether, a certain question is valid or not, or whether part of it can be used for something else, or whether, just whatever kind of research question they're trying to ask. So again, the best thing to do is just to take a deep breath, use a minute for every question. There is a time limit on the National Registry exam, just like there was on the FISDAP unit exams and ERE, but almost nobody runs out of time, okay? The most common thing, and I've been harping about this all semester, but the most common thing for people to do is rush through a question or rush through an exam. And remember, this exam is going to behave like those Canvas quizzes. You're going to get to see the question, you're going to get your first whack at that question, and you're never going to see that question again on that quiz or on that exam. You won't be able to go back and review it. You won't be able to go back and change it. You analyze the question, spend an average of a minute on every question, and make sure that you've decided, that you've picked the best answer or the least worst answer, or you've looked at the question and decided, well, If it was me or a family member, of these 4 things, I would want, I would want the EMT who is treating my family member to do B and probably not C, and definitely not A or D. Questions so far? For me?
These pilot questions, are they part of this total score of the NREMT?
No.
Okay.
No. They're not factored into a candidate's performance, is what it says on the web page in front of you. And but again, almost nobody gets 90% on FISDAP exams, and nobody gets 100% for the same reason. Statistically, they need to have a ceiling for those exams, number one, and number two, they sometimes have pilot questions on those exams as well. So they want to see how those questions behave as well. But with this computer adaptive test, that is, going to be a part of this exam, and you're not going to be able to know which kind of question you're getting. So you would treat that question, even if you thought, this doesn't sound like a real question, you would treat that question as if it were counting towards your score, definitely. Other questions? Does everybody understand the adaptive part of the National Registry exam and the fact that the number of questions you get will, I believe it's still a minimum of 75. They use the same kind of statistics that FISDAP does to determine what the cut score is. Everybody understands the testing situation, either be done online through with even more security than the Proctorio we've been using, or you'll be doing it in a infection controlled environment at a testing center. So sometimes people go and get from Barnes and Noble or whatever, if you went on their website or you went to a bookstore and you went to the test prep section, and there's books on prepping for the MCAT for medical school, or NCLEX for nursing or whatever. There's also EMT and paramedic National Registry test prep books. And again, those typically aren't the best way to refresh your knowledge. The best way to refresh your knowledge is to make a learning plan, make a study plan based on those ERE learning prescriptions. But if you need more practice kind of taking exam questions, remember that those exam questions in those test prep books, they maybe explain the answers well, they maybe help you kind of work with the knowledge. But there's 2 things I want you to remember about that. One is the people who write those books are not as good at writing test questions as the people at FISDAP or at the National Registry. So the quality of questions might not be as good, number one. But number two, you're here on this Zoom call right now because you passed an exam that puts you, depending on the level of cut score you got, puts you at somewhere between 85 and 95% chance of passing the National Registry's exam on the first attempt, okay? So as you sit right now, wherever you are right now, you are ready for this exam, all right? You should take your ERE learning prescription and you should spend a couple of weeks studying. I would personally suggest not spending more than 3 or 4 weeks before you take the National Registry exam. You have 2 years, but I strongly suggest that you don't wait more than 3 or 4 weeks. at the most. If circumstances don't allow you to, then do it when you're ready for it. Do it when you're not having, some kind of childcare crisis at home, or whatever's going on, or work is at high speed for the holidays, or whatever your situation is. Be ready, be rested, be in a good emotional state, all those kinds of things. But your best chance for passing the National Registry exam is taking those ERE learning prescriptions and doing a little bit of studying and getting in there and getting it done. You're primed to pass the National Registry exam on the first attempt, and that's the majority of feedback we get. Every once in a while, we get somebody who was like, yeah, I was a little bit weak in obstetrics and pediatrics, and I didn't pass that part of the National Registry exam. And usually those very few folks that don't pass it on the first attempt can go back and kind of buff up their knowledge. And as long as their other scores don't drop, then they'll do fine. But statistically, nationally, if you don't pass on the first attempt, you can reattempt a second and a third time, but your chances of passing the National Registry exam the second and third time actually go down. They don't drop precipitously, but they do go down. So don't walk into that National Registry exam thinking, oh, well, I'll have other attempts. I can reattempt this like one of those formative quizzes on Canvas or something like that. Your best attempt is your first attempt. And so make sure that you're ready for it. You are ready for it, but make sure that you've, kind of gotten the ducks lined up and done a little bit of studying and kind of boosted your confidence in maybe the few weak areas that you might have. Questions?
I do have one question.
Certainly.
If we chose to do on-site testing, how and when will we receive the dates and the times and all of that? Is it once our application's processed, or do we need to keep checking back and then it'll let us select the dates, or it's going to be sent in an email?
So, like I said, once I email out to the group that the verifications have been submitted, it's all between you and the National Registry and Pearson. So once your verification shows up in your National Registry account, you will pay your fee, and then the National Registry in that dashboard is what I'm told is in that dashboard, you will then have information and links that you need to contact Pearson and set up a testing date and time. At that point, it's all between you and the National Registry and Pearson. We can't and have no way of being involved at that point, or are not supposed to be involved. So I've never heard any complaints about the Pearson process, and I've mentioned that if you do it remotely, there's going to be more security, but it seems to work pretty well. And I would suggest waiting to pay the fee until the verification's done, but that's entirely up to you. The biggest bit of feedback that we get back on the campus is people come back and tell us that the National Registry exam was so much easier than taking the ERE, mainly because it was fewer questions, but also because they knew their stuff. And that's the typical kind of feedback we get. And if you have concerns or questions about the process after verification, or there's a hang up with verification or anything related to testing, it's going to be between you and the National Registry. Okay? Did that answer your question?
Yes, thank you. Sorry, my microphone's not working.
That's all right. Other questions? So it basically also outlines on the National Registry exam pretty much what I've been telling you about it, you know, being rested, not just the night before, but probably a couple of days before. And, you know, not eating too much, but not going there hungry, getting there way ahead of time, or being ready at your computer at home if you're doing it remotely way ahead of time. And, you know, it gives you some suggestions and reiterates the kind of thing that I've been talking about. Again, you're going to log into that account and go to your dashboard. And the National Registry, from what we hear, when your verification is completed, they don't send you a message. You have to keep checking your dashboard and your application status on the National Registry's website. The day after you take the exams, your results should be posted online. And you're actually, from that moment on, you're nationally registered, and somebody can go to the National Registry website and confirm that you're a nationally registered, nationally certified EMT. Then they will send you a card in the mail, or you'll print out a card, or whatever works, whatever they're doing these days. And then you'll go through the California state certification process, which I'm going to talk about next, unless there are other questions.
I have a question.
Yes.
So just to clarify, if we take it at home, it's not it's going to be the full 120 questions. It's not going to be interactive, or I can't think of the word.
Adaptive?
Yes.
Is that what is that the information you got from the National Registry?
No, it's the information that I got from somebody that already took the exam, but she took it in person. She said that's like what she thought it was going to be like. But I went to the National Registry website, and it doesn't say that it's not interactive.
Well, it's going to be interactive regardless. It's going to be adaptive, whether you get 75 questions or 120 questions or what have you. I assume that is going to be a function of what the algorithm determines you need as far as questions to determine whether you're competent or not competent.
Okay.
So I don't know that there's a number of questions different between the remote and the in-person testing. I just take it as it comes. It's either way. You know, it's going to you're going to get what you're going to get, and it's probably going to be fine.
Okay, thank you.
On here, there's a statement that says provisional certifications will no longer be issued after December 31st, 2020. Now, does that mean that we will have to do ride-alongs before we'll actually be able to get certified?
The national EMS standards do not require anything like that. That is a state requirement.
Got it.
So,
okay.
So what happened in spring was everything went remote. We had no on-site labs at a certain point. So there are folks who needed their rest of their National Registry skills verified. You don't. You've been through a full semester of lab and had all your National Registry testing done. So you will not get a provisional national certification. You will get a full course completion and full psychomotor skills, cognitive course completion and psychomotor skills course completion verification from us. You will be fully registered and certified with the NREMT.
But on the
California state, you might be provisional.
Got it. All right, thank you.
Mm-hmm. Other questions? Okay. If you have questions about the Americans with Disabilities Act, please go to their website and click on that information. It has information specific information about accommodations for testing. All right. Okay, now, let me know if you have other questions. Otherwise, I'm going to proceed to talk about the state certification situation, and then we'll take a break. Awesome. Caitlin, are you there? Yep, I heard. Yeah,
Hello? Yeah, sorry, my
Hi.
microphone's also having trouble.
that's all right. Can you see the whiteboard? I'll take that as a yes. Foster, can you see the whiteboard?
Oh, yes, I can see the whiteboard, sorry.
Okay, thank you.
Yes, I can see the whiteboard.
Excellent, thanks. All right. So, so you've created your National Registry application, and we're going to do the verification. Both the cognitive and the psychomotor skills verification. You're going to pass the National Registry exam. And then you don't certify with the state of California. Paramedics do, but emergency medical responders, EMTs, and advanced EMTs go to a California, a local EMS agency or a LEMSA. And you can find a list of those at the state EMS authority's website, emsa.ca.gov. Those are dots. All righty. So you're going to go to a LEMSA. Most people, like, they live in Sacramento. They go to Sacramento County LEMSA, and they used to be a little trickier to get it done. But now I think they've gone to a fully remote way of doing it. And the LEMSA where you certify for California does not have to be the place where you work. You could certify as an EMT in Sacramento County and then drive to Solano County and work as an EMT. It doesn't matter. Any LEMSA that through which you certify is going to give you a state EMT certification card. It's a gray card, and it says California State on it, and it is your state EMT certification. All right. It's just that there are so many EMTs being certified and everything that the state is unable to handle it. They have National Registry do the testing, and they have LEMSAs do the certification. If you start working in Solano County, or then when you recertify, you're probably going to want to recertify through Solano County or Sierra Sacramento Valley EMS Agency if you work in one of the 10 counties that make up the SSV EMS region, or Mountain Valley EMS, or LA County EMS, or Alameda County EMS, or wherever you work, because within that local EMS agent service or local EMS agency, within that service area, you are a disaster service worker for that area. You need to get protocol updates for your EMS system. You need to get newsletters and, you know, whatever for the area you work in. And the way you do that is typically by certifying in that region or in that county, so that you're a part of the community there in that EMS system. As far as, well, we'll talk about jobs later. So you get how you get that EMS cert is because we sent you in that self-addressed stamped envelope, we sent you a course completion certificate and a California skills verification, because California has some different skills. Also, there's no national standard about how many hours of EMT coursework you need. So the state has requirements for hours, and that course completion certificate is going to tell you how many hours you completed in EMT education and training. And then again, there are different skills like childbirth and Narcan and that kind of thing that aren't required by the National Registry, but are required by the state. So when you certify from the LEMSA, you're going to need these course completion certificates, and you're going to need to keep the originals. The originals have a wet signature on them. They have my actual pen signing the paper, and you need to keep those in a safe place, because if they're ever audited, you need to have the original documents. Likely, you are going to submit them to the LEMSA scanned, you know, or as PDF files or whatever, but you need to keep those originals for them to be able, at some point, if they want to verify that they're actual legitimate documents. Questions so far?
I'm
Yeah.
sorry, can you repeat what documents you recommend we keep?
Okay, hang on just a sec.
You should probably keep all the documents, to be honest.
But like, I'm asking like what documents though?
It was the course completion verification document and the California skills verification document.
Gotcha.
Yeah, so exactly. So this whole process up here, this is totally remote, right? That makes sense? This is probably going to be totally remote too, but these documents are something you need to keep for at least 2 years, because they might come back to you and say, wait a minute, you know, we think that, you know, you forged those documents. We want to see the originals. And that's true of every like continuing education certificate and everything you get. You have to keep it for a certain period of time, because you could tell your LEMSA, hey, I got 24 hours of continuing education, and you know, here's my application to recertify as an EMT. But at any time they could come back and say, oh, well, we're going to audit you, just like somebody auditing your taxes. They could say, okay, you need to send in, you know, all the certificates for the CE you claimed you took between, you know, January 2021 to January of 2024 or whatever, or 2022 or what have you. And they do those kind of snap audits every once in a while, just to make sure people are actually actually do the CE or have the course completions that they claim they do. So did we get all the questions resolved about those kinds of things?
I have a question.
Yes.
Pretty simple, I think. Like, what do we need to do? Like, what do we need to, like we do in the NRE application, we pass the NRE, and then I'm kind of lost on the LEMSA and like also the documents. Like, how are we gonna get those documents? Do you have them? Or are you gonna send it to us?
Did you give me a self-addressed stamped envelope?
Yes, sir.
Then you're gonna get these documents right here are gonna come in that self-addressed stamped envelope that you gave me. And they're gonna come after we do the verification for the National Registry. Or, I mean, they're gonna come after because the mail is gonna be slower than the verification probably.
Okay, and then as far as skills verification, so we did OB. Do we have to schedule anything with them to take any other skills?
Nope, we do all your skills testing
Okay, cool. So it's just
at
like
the national registry level and at the state level, and that's why you get a second piece of paperwork in that envelope that has a separate California skills verification. Someday
Awesome.
maybe we'll do that. They'll arrange so that we can do all that verification online. But right now, you have to do it with the LEMSA, with these two pieces of paper that we're going to mail to you.
Okay, thank you so much.
Other questions?
Yeah, so for doing the LEMSA, is that like an online process that once we pass, then we just go online? I'm a little bit confused about what is our responsibility to like do at that point once we pass the national registration.
Well, the short answer is it's your problem because it's going to be your professional responsibility to figure that out. The long answer is that what people tell us is that there used to be local EMS agencies that made you come to their location at, they only had like 8 hours a week where you could go and submit your paperwork and everything. I think there are places that still have the ability for you to drop off documents or mail them documents. But for instance, with Sierra Sacramento Valley, which is Placer County and all the other 9 rural counties to the north and east of Roseville, those counties in that EMS agency, it can be, if you want it to be, it can be completely remote. Understanding that even if you submit scanned documents or, online, making an attestation online saying, I took this course, I completed this thing, here's a copy of all the documents, blah, 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 that they could audit you at any time and you have to cough up the original documents. Does that make sense?
Yeah, so pretty much doing the NREMT is going to give us the national certification, and then providing all the documents on the LEMSA gives us the certification at a state level?
Correct. And, for instance, in the past, the National Registry, you get your test results the day after, and it's like, I passed the National Registry exam and I'm now nationally certified as an EMT. Well, that's great. But some LEMSAs say, yeah, well, that's awesome. But when you get that physical card from the National Registry in the mail, copy it and send it to us with your EMT application for California. Does that make sense?
Yeah, that makes more sense.
Some LEMSAs will say, great, turn in your documents. And they go to the National Registry website and go, yep, they're nationally registered. And they give you California state certification. Does that make sense?
Yeah.
So I don't know individually what the process is from local EMS agency to local EMS agency. Like it's kind of a stale joke, but you've seen one EMS system, you've seen one EMS system. They have to follow state law, but how they get it done may be a little different from place to place. But we give you those documents. We give you these documents that you need to turn in, and they will, on their website, they will give you really good instructions, at least most of them that I've seen, give really clear instructions about how you need to apply to the LEMSA for California state certification. Does that clear things up?
Yeah, that makes sense. Thank you.
Any, yes.
One last question. As
Uh-huh.
for their California skills, we have all of them, including Narcan. That's a fact.
Yep.
Okay. Awesome.
That's when we did the pharmacology stuff in lab. I signed everybody off on that.
Thank you.
Mm-hmm.
Is there a fee to get or for the California application?
What do you think?
Probably.
Yeah, and in fact, I think it's more than the National Registry, but I don't know for sure. But yeah, at every stage of this, somebody's going to want to fund their agency, many of whom are very underfunded, in any way they can, and certification fees are one of those ways. In fact, they charge the college tens of thousands of dollars just for the privilege to teach EMT and paramedics. So yeah, they're going to be fees. Other questions? And I don't know if the LEMSA certainly sets their own fees. I don't know if the state has a cap on the fees, but you might check a couple of different EMS agencies. The fee may be higher or lower at one or the other. I don't know. Other questions? Okay, so once you're California State EMT certified, then you're going to need to recert. And again, the details are something I'm not terribly clear on because we don't do refresher or recertification courses at ARC anymore. And also, it's changed a little bit, but the basics are that you are going to have to do through your employer or some community college or private institution or whatever that does research, that after 2 years you're going to have to recert, and you have the choice of recerting on the national level. You could do the National Registry certification. It's all done online, and they accept the CE that the state approves, or there's a national body called the Continuing Education Board for EMS, and they give their stamp of approval to CE that the National Registry will accept. So if you get state approved or nationally approved CE, then you can input that on the National Registry's website and pay all of $25. A couple of years ago, they raised the fee. The fee's been $15 to nationally recertify or re-register since the 1970s, and they had to raise it to $25. And that gives you tremendous job mobility. And it also is a little more prestigious, but that's your choice to keep that up. If you only want to maintain your California cert, then you have to do however many hours of continuing education. All right, continuing education hours or continuing education units. Also, you have to do a skills checkoff, which is basically this same skills up here that you submitted from us. You're going to have to go to your employer or an educational institution of some kind, and your training officer or someplace that does EMT research classes, and you're going to have to get your skills checked off every 2 years. And I strongly suggest you do not procrastinate about that. You could be certified as an EMT on day 2 of being a California State EMT or a nationally registered EMT. You could start on your continuing education. All right. You don't have to wait until the last month before your certification expires. And guess what happens if your certification expires while you're working as an EMT? Any guesses?
You go to jail.
No, you don't go to jail.
No longer work as an EMT.
Your license is revoked.
Yeah, no. Well, your certification is, but your employer is going to at least suspend you, and if it doesn't get taken care of within a certain period of time, they're going to fire you. That's the most likely thing to happen. And hopefully you would get suspended first, and they would give you a chance to fix it. But that's you know, that's probably the best case scenario. If you work as an EMT with your certification or any of your certifications expired, yeah, that could incur some legal liability. You could get in some deep trouble for that. And that includes everything. If you drive a vehicle and your vehicle license is expired, or your ambulance endorsement is expired, or your CPR, if you're working as an EMT and your CPR card is expired, or your EMT cert is expired, or your what else? What else would an EMT have? Your hazmat first responder certification, or any of the things that you're supposed to have to function as an EMT, then you know your employer should be tracking that, and they should be yanking you off the rigs and sending you home without pay, and they might fire you. So if they don't do that, then you and your employer could be in some pretty deep legal doo-doo if something bad happens. And it's, again, just because your CPR card expires doesn't mean a week later that you forget how to do CPR. But again, it's a line you cannot cross in a healthcare field where the public is told to implicitly entrust us with their health and safety. It's just a line you can't cross. And your employer might do training and stuff that they require you to do. And if you don't complete the training, then they may suspend you as well. So there's a lot of work keeping this up. But if you keep track of it and plan it out and don't wait till the last minute, it should work out pretty well. Any questions? All right, so we're going to take a break. It's 11:06, and why don't we come back at 11:20? And if you have more questions about this process, we can do that. If not, we'll jump into doing some topic review. All righty. Okay, see you at, what did I say, 11:20? 11:20.
Yes, sir.
Thank you. All right, folks. So we're going to get started again. And did any questions or comments come up about certification? if something comes up, send me a chat, and we can, address it before the break or whenever there's pause and what we're doing, we can chime in and make sure everybody's understands what the process is and answer any questions they have. You need to have that application finished by the end of today, and you need to get that application number submitted through the assignment on Canvas. So please don't put that off. That's going to make headaches for the both of us. Alrighty. So what I have is basically a group learning prescription. Since part of the group took one ERE and another part of the group took a different ERE, it's two different learning prescriptions, but they all have basically the hit parade of stuff that people missed on the ERE exam. And it's useful because, if there's something that didn't get conveyed well enough during the course, or that's a difficult type of material or topic, or maybe it was part of a pilot question, or, one of those really super hard questions on the FSDAP exam. We don't necessarily know for sure if that's the case, but lots of times we can look at, this learning prescription. And I look at the one for, I think it's the ERE2. And if you go to Airway, it says that 94% of the people who took that exam, so 16 students out of my class, missed a question on assessment and treatment of a patient with a foreign body airway obstruction. Where do you go for information about relieving a foreign body airway obstruction? Where did that information come from in your EMS education?
CPR.
Exactly, your CPR course, right? So you're CPR certified, so we didn't spend a lot of time reviewing that. That's not our job. You're certified in that already. So there clearly needs to be some review by people on those American Heart Association standards. So that's one of the first things to point out, is that not only were those FSDAP unit exams based on AHA standards, but any exam you take for the National Registry or for the National Registry or for recertification or some other kind of certificate, like a pediatric life support course or something along those lines. Any kind of certification you get or any kind of test you're going to take in EMS anything having to do with CPR, foreign airway obstruction, ventilation, all that kind of stuff is going to be based on those AHA standards. So you've got to keep up on those AHA standards, and they change. Every 5 years, they review all the research and medical literature and stuff, and they decide that, you know what, we're not going to shock 3 times and then start CPR. That's what we used to do. Found somebody in a shockable rhythm, you'd shock them, wait, no response. Okay, analyze again, shock, wait, still no response. Analyze again, shock, oh, still dead, I guess we better do CPR, huh? That's the way it was done all the way through the late 80s and 90s. And that seems crazy now. But, now we do 2 minutes CPR shock, 2 minutes CPR shock, and we're doing compressions at any time we're not analyzing or shocking. So it's going to change. You need to keep up on it, and you need to remember that these exams, including the National Registry exam, is going to be based on AHA standards. If you go to, education, EMS education symposia, or, EMS industry conferences, or you go into any of the places where I've done presentations or been a participant, and you go to one of these National Registry Q&A sessions, lots of EMS educators will ask a question, to the effect of, what's the thing that students miss the most on the National Registry exam? And they asked that question because, you know, nationally, only about 70-75% of students, EMT students, pass the National Registry exam. So often the big question is, well, what is it they're missing the most? And the answer from pretty much everybody involved with the National Registry from the late 90s until just recently was the most common questions that are missed are on the topics of ventilation, oxygenation, and respiration. And being clear on that is really important. The trend now is maybe EMS educators are doing better teaching those kinds of things, and maybe the textbooks and all that are getting better at allowing people to understand the difference between negative pressure ventilation and positive pressure ventilation. But you can do positive pressure without ventilating a patient, like with a BVM, because it's CPAP is positive pressure, but it's not ventilation, and non-rebreather mask is oxygenation, but it's neither positive pressure nor ventilation. And so you kind of have to be able to keep all these things straight. But apparently people are doing better with that. The main blind spot apparently with EMC students is pharmacology. And the amount of pharmacology that you need to understand has increased dramatically, even in just the last 3 to 5 years. You've had, not only have you had EpiPen and oral glucose, you know, to deal with, or activated charcoal, which seemingly is not being used in many EMS systems anymore. But you're now expected to understand actually how epinephrine works and the effects of the sympathetic nervous system. But bronchodilators that are beta agonists work a little differently when they affect the sympathetic nervous system. So you need to understand the differences. And now there are some medical directors that are saying, yeah, you know, an EpiPen is great for anaphylaxis, but if the patient's having severe bronchospasm, you should use it for that as well. And then there's Narcan and aspirin and nitroglycerin and all these other kinds of things. And trust me, it's just going to get crazier, because there are many medical directors that not only trust you now with pulse oximetry, which is something that you need to understand really well, but they're saying that EMTs, if they're going to put an eye-gel on the patient, then they should be monitoring the patient's end-tidal CO2, how much CO2 they're putting out when the patient is ventilating. So give that being a big topic, what questions do you have about that above and beyond AHA standards? Did everybody understood the spiel I just gave and understand the kinds of concepts they need to be familiar with? Oh,
Yes.
thumbs up. Nice, thank you. That's great. Good, glad to hear that. Those concepts are really important, and we had Professor Ayala and I had that discussion last night with the students. There are so many things that students want to be able to say, well, what about pulmonary edema? What are we always going to see in pulmonary edema? What are we always going to see, you know, and what's always going to be the treatment? And the answer is there's no answer for that question. Some patients are the same. If you've seen one postictal patient, they're probably going to be pretty much the same as every other postictal patient. Some are going to be taller, some are going to be shorter, some are going to be female, some are going to be a different color. You know, they may vary who they are, but the syndrome of being postictal is going to be pretty much the same every time. But the way people suffocate to death, that happens in different ways. And what you do for the patient who has a gag reflex, but is in respiratory failure, is going to be different than the patient who is falling asleep and can't keep their eyes open and is foaming at the mouth, you know, with pink frothy sputum. So anyway, we can move on from that if nobody has any questions for that. But let me just look over at the group learning prescription there, see if there's anything else I want to rant about. On that ERE 2, 76% of students missed a question on determining the appropriate oxygen delivery device based on a patient's signs and symptoms, right? So that's going to be an issue of, as I just alluded to, that's going to be an issue related to, what the patient's level of consciousness is, what their skin signs are, what their respiratory rate is, how labored their breathing is, what their SpO2 is, and you know, what their history is. Plus, how many words per breath are they speaking? What's their exercise tolerance, right? So somebody who is breathing, say, 24 times a minute, it's labored, they're having some bronchospasm, they have a history of asthma, and if it were a, you know, their SpO2 is 90 or 92, we'll say. If that were a, you know, ARC track star who is having an asthma attack at home, you might put that person on a cannula at 6 liters per minute or a non-rebreather and coach them with their breathing and help them with their MDI and, you know, take them to the hospital. But if it's the 76-year-old COPD patient whose exercise limit is walking to and from the bathroom or to the door of their trailer when the Meals for Wheels people come by, and they seem to be breathing okay, you know, but you may say, you know what, their capacity to breathe like this for the next 15 or 20 minutes on the way to the hospital is not that great. So we wouldn't have put CPAP on the track star, but we're gonna put just the lowest level of CPAP on this woman because she needs some relief from the effort of breathing so that she doesn't go into respiratory failure on the way to the hospital. Does that make sense to everybody?
For some reason, I thought that we didn't generally use CPAP within our scope of practice within what we do.
Oh, hell yeah. It's
Okay.
in the BLS scope of practice for California. Whether you're authorized, you know, in your local EMS agency to do it without a paramedic present is another question. But it totally is a BLS skill, and I'll go on calls, and before I can get the words, before I can turn to my EMT partner and say, hey, let's put the patient on CPAP, you know, they're assembling the device and hooking up to the oxygen. I'm like, yeah, nice idea.
Okay.
Right? So it's like glucometry. I think Professor Ayala was saying that in San Joaquin County, EMTs are not allowed to do blood glucose checks. Again, you know, my EMT partners don't ask; they just go ahead and do it. if they realize that, hey, this is an altered mental status patient, or this is a diabetic, or whatever, you know, again, I'm talking to the family, and I turn around and my EMT is, you know, the patient's in pulmonary edema and they've got them on a 12 lead and they're, you know, and they've got them on CPAP. And I'm like, oh, okay, well, I guess I don't have to, you know, I don't have to fool around with that. So, you know, it's again, you've seen one EMS system, right? Now, the local EMS agency may say that, oh, you're working on a BLS ambulance, 2 EMTs on a BLS ambulance. Well, you definitely are required to have an AED, but you're not required to carry CPAP. If you need CPAP, you call for ALS. Does that make sense?
Yes, thank you.
Okay, you're welcome, of course. What other questions?
At what point do we administer things, at what point do we administer medications like epi auto-injector and bronchodilators? Some of the test questions I've seen and what it'll display as the right answer make it seem like we do it like sometimes it suggests before oxygenation or something like that.
That's a good question. Not a lot comes before applying oxygen, but so that's a question that's a part of the question I can't really address. The short answer, of course, is follow your local policies and protocols. But the long answer is that it's true that epi would be something where you wouldn't be walking through every point of the National Registry skill exam, medical assessment skill exam before you get to giving that patient epi, right? You would be doing a primary assessment. There would be 2 or 3 questions you'd ask during your sample history. You check for, life-threatening signs of anaphylaxis during a quick secondary, like listening to lung sounds and checking for airway swelling and, getting the patient's vital signs. But, at whatever point that patient met the criteria, whatever point during your assessment that the patient met that criteria in your protocols for giving epi, you would stop your assessment and you'd give them epi. Does that make sense?
Yeah.
I know that doesn't help you with test questions, but again, look at the 4 answers and decide, if I was being treated or a family member is being treated, what would I want to be done? And is that consistent with the principles and practices and what have you? So a question, for instance, about nitroglycerin, clearly you would get vital signs before you administer nitroglycerin because you've got to know what that patient's blood pressure is. At the same time, I'm not saying that there's a question like that out there. I'm just spitballing based on my experience or what have you. A question that came from the textbook publisher might have something that says you'd call medical control, because that's what the principle and practice is in the book, is that medical control authorizes you to use an EpiPen. But that in reality would be a waste of time. If the patient meets the criteria for your standing order for giving that patient epi, you would give them epi. So you have to, answer those questions, understanding that epi might become for some of those important things that are in the assessment. But if one of the answers were scene safety, nothing other than PPE comes before scene safety, right?
Yeah.
Okay. Other questions? All right. So on the other ERE, 84% of the students, or about 18 students, got a question incorrect about signs and symptoms of epiglottitis. So again, when it comes to any topic like childbirth, for instance, those things about what if you have a presenting part? What if you have a prolapse cord? What if the baby is delivering breech, all these kinds of things. You need to kind of know those things off the top of your head because there are life-threatening things, and you just kind of have to memorize those things in some way. Some things you can think it through by knowing the concepts. If you're talking about shock, if you're talking about congestive heart failure, okay, it's all about the plumbing. We chalked out on the sidewalk, all the different circulatory system and the lungs and all that kind of fun stuff. And we basically, identified that, hey, some of the problems that people have are just a plumbing issue, and you need to recognize what part of the plumbing isn't working properly and what the upstream or downstream effects of that plumbing failure is going to be. That pump failure, that container failure, that volume failure, or maybe if there's some kind of obstruction, for instance. So those kinds of things take a clear understanding of the concepts, and you can usually kind of think through those. And if you don't know the answer off the top of the head, then you can reason through and find that information. Something about epiglottitis or croup or a full airway obstruction versus a partial airway obstruction, all those things are just going to be things that you just have to know. They are information you need to memorize, and you need to be able to pull up at whatever moment you need it, whether it's a multiple choice question or it's a call out in the streets, and the patient speaks very weakly, and they're making kind of gagging noises, and their skin is pale, and you recognize it's partial airway obstruction, and you need to position the patient and give them high flow oxygen and take them to the hospital, possibly lights and sirens, but it's not somebody who's going to get abdominal thrust / Heimlich maneuver or back blows or, those kinds of things. Questions? By the way, epiglottitis is not something we see as much anymore, but again, you have that patient who's having difficulty breathing. So if they're old enough, they're going to be tripoding, and their airway is starting to swell. So they're going to have difficulty speaking, difficulty swallowing. They may be drooling, especially if they're a child. And they're going to have flu-like symptoms, probably a fever. And you do not want to look in or stick anything in their airway because it could cause that swollen epiglottis to swell shut. Anything about airway in general?
What about treating a patient with a stoma? I feel like yeah.
What's the person with a stoma's problem? So,
maybe that they have like some secretion or some type of fluid in the stoma that needs to be suctioned.
Yeah. You would treat a stoma like it's a big trach tube. So you would sterile suction, the patient. If there's stuff dried in there, you might have to put a milliliter or two of sterile water or sterile saline in there to kind of moisten things up so you can suck it out. You want to, when people cough out of their stoma, they spray real hard. So you want to have a PPE on, and you want to be standing off to the side, especially if, you put a suction catheter in there and it tickles their airways and causes them to cough. And then, so in that way, it's like a trach tube, or even like the oropharynx. You got to keep it clear. There's no airway, there's no BLS airway that you can put in there. So if you ventilate, you're going to need to use a BVM. And if it's an adult, use an adult BVM, but you're probably going to be using what size mask, Mr. Keefe?
Would you use a pediatrics?
Yeah, you only need one as big as the stoma, and you need to fit it between their chin and their, sternum. So, or manubrium at that point. And so depending on how much neck that person has, you may have a kind of small area to get that mask in. So you use a maybe toddler or infant mask, but you're ventilating the patient with a BVM. Can't get an eye gel in there because there's no larynx to put it around. You're below the larynx. A paramedic could put an endotracheal tube into that stoma and close off the airway. But as far as respiratory distress and respiratory failure, you could give a nebulized treatment with a mask, or actually that's not your scope practice. You might be able to, help that person with an inhaler. They may have an MDI that has a spacer, and that spacer has a little mask on it, and so that they can breathe bronchodilators through their stoma, but you won't be able to use CPAP, for instance. That won't work and might be dangerous.
Thank you.
Other questions? So one of the other things on the ERE for airway is that it says treatment of respiratory failure. There's 86% of the students got that question wrong. I'm guessing that that's probably a question that was a little harder than most questions. But one of the things that both Professor Ayala and I wanted to point out is that make sure that you get the nomenclature right. So one of the frustrating things about medicine is sometimes there's 2 or 3 different things that describe the same thing, or, like the sympathetic nervous system is also called the adrenergic, system. And so and parasympathetic is the cholinergic. So, and there's EMS jargon, a cot, a gurney, a bed, a stretcher, all these things might refer to the same thing. But when it comes to respiratory distress, someone who's in respiratory distress is breathing adequately, but they're having labored breathing. And respiratory distress is usually severe. It can be described as mild or moderate or severe. But if you would tell me we've got a 62-year-old male here in respiratory distress, I would assume that that patient is having serious breathing problems. Otherwise I might hear you say something like, the 62-year-old male is having some mild shortness of breath or something along those lines. But respiratory distress is distress. It's like a distress call for a ship. They need help, and they need urgent help. Respiratory respiratory failure is a situation where somebody might be making some effort to breathe, but it's not adequate enough. And the respiratory distress patient might have gotten CPAP, for instance, but the respiratory failure patient isn't maintaining their airway well enough and isn't breathing adequately enough, and is probably having some altered mental status. And so CPAP would be contraindicated in those patients. You'd have to probably move towards what?
A BVM.
A BVM. And if you're doing BVM on a patient, even if they're still breathing, making some respiratory effort, you're going to need to be ventilating them adequately and working with their ventilations, not against them. Also, you should be seriously considering what other intervention?
An NPA.
Yeah, an NPA, absolutely, some kind of airway adjunct. And then respiratory arrest is a situation where someone is not, not breathing at all, or they're having agonal respirations, or they're having, just ineffective, infrequent, or patterned breathing that isn't enough to maintain their oxygenation and respiration. So like chain stoking, for instance, something like that. So those people definitely need to be ventilated. And if they're unresponsive, then they would be getting an OPA or an iGel if they're an adult. Questions? There's also something on here about the classification of breath sounds. So again, make sure you review that. Listen to the audio recordings, read the descriptions in the textbook, and make sure you understand that, you know, wheezes is associated with bronchospasm, and bronchospasm is associated with asthma, and COPD and anaphylaxis. And, you know, make sure you have all those connections mapped out. Same with crackles and rails, which are the same thing. Crackles and rails are just two terms for the same thing. And rhonchi, you know, if you have somebody in respiratory distress that has clear lung sounds, you should be thinking of what problem?
Can you ask the question again one more time?
If you walk up to a patient and they're clearly having respiratory distress, and they have rapid breathing, and you listen to their lung sounds and their lung sounds are clear, what life-threatening condition should jump to mind?
Pulmonary edema.
Edema is fluid in the lungs, so you'd hear
Or
what?
pulmonary embolism. Sorry.
Embolus, yeah, a pulmonary embolus, right? Because the pulmonary embolus is clogging the pulmonary circulation, but it's not causing abnormal lung sounds. The lungs are still inflating and deflating just like they normally do. And so you, unless there's some damage to the lungs for some reason, you're gonna be hearing clear lung sounds. And the patient may be hyperventilating from another reason, but you need to kind of run down the possibility that they might be having a pulmonary embolus, because those can be fatal very quickly. All right, any questions about airway management, respiratory diseases, treatment of respiratory conditions? All righty. Let's see. Let's talk a little bit about cardiology then. Oh, there it is. All right. So on one ERE, the top thing in cardiology is signs and symptoms of congestive heart failure. Again, like I mentioned before, this is kind of a plumbing problem, and you need to really be able to think through what's the issue with the plumbing and what's going to be the resulting signs and symptoms. And remember that you can have right-sided failure and fluid retention, either immediately in the jugular veins or over a long period of time with dependent edema. Or you can have left-sided failure, and that's usually going to be associated with hypertension, and that pressure and the pressure in the arteries and that failure of the left ventricle to work well enough is going to cause blood to back up in the lungs, right? Or fluid to back up in the lungs. Now, you can have one or the other, or you can have both at the same time. So it just kind of depends on your history. And if somebody has a history of CHF, you know, they may know they take a water pill. So that lets you know that, hey, they're on a diuretic, so they have right-sided failure. But today they're complaining of shortness of breath, and you listen to the lung sounds and you hear some crackles, and And now you realize, hey, they don't just have right-sided failure, they now also have left-sided failure. And you would, manage that patient appropriately, which could include CPAP and ALS treatment.
I feel like this is kind of a silly question, but how do you determine that they have like a lung failure?
You mean, what do you mean by that? Like whether they have left or right-sided heart failure, or whether you have pulmonary edema in the lungs?
Pulmonary edema.
It's those lung sounds. You can have, two things about that. One is you can have light crackles, which, sounds like rubbing your hair together, or you can have coarse crackles, which sounds to me, and a lot of people, sounds like bacon frying. And those are all signs of fluid in the lungs. You can have flash pulmonary edema from other situations. High altitude can cause pulmonary edema. Drowning, near drowning can cause pulmonary edema. Toxic inhalation can cause pulmonary edema. An MI could cause pulmonary edema. But for someone who has congestive heart failure, it's a chronic condition, they're going to start having those crackles, and it's the fluid's dependent in their lungs. So if they're laying down, that fluid's going to be across their lungs. If they're sitting up, that fluid, those sounds of crackles are going to be lower in their lungs. And if they're sitting up, as the crackles rise through their fields in their lungs, you'll hear them higher and higher up on their chest until there's a point where they're spitting up white frothy or pink frothy sputum. And I've actually, when I was an EMT, my first pulmonary edema patient was a fulminating pulmonary edema patient. He had bubbling pink foam coming out of his nose and mouth. And we didn't have CPAP at the time. So I didn't take his vital signs. I didn't get a history. We put him in the ambulance, and I did bag valve mask ventilation on him all the way to the hospital with him sitting up and me behind him, reaching around with the BVM and doing bag valve mask ventilation. Every time he took in a breath, I squeezed the bag and I kept a really tight seal. And we kept the foam down low enough in his lungs that he was able to remain oxygenated well enough that he didn't drown on the way to the hospital.
So that's a severe enough thing to be like a load and go situation. Okay.
But back then, yes. Now you'd probably slap some CPAP on that guy and call ALS, and he'd probably be fine.
Okay.
Does that make sense?
Yes, thank you.
Yeah. But it could turn into a load and go situation. Anyway. And that did answer your question.
Yes.
Okay, great. Other questions before we, airway related or moving into cardiology? There's another one on here that has to do with MI and an MI treatment. And so a couple of things to remember, it's probably not something that is going to be, emphasized on a national registry exam, but remember that people do have atypical presentations. That doesn't mean you have to read a lot into a test question about MI, but, if someone is having all the signs and symptoms of an MI, and maybe they're having shoulder soreness or heartburn, like indigestion or something, and they're having other signs of MI, then that may be an atypical presentation of MI. And sometimes people don't have any kind of chest pain or discomfort at all. They're just showing those other kinds of signs like dizziness and nausea, vomiting, shortness of breath, other kinds of signs and symptoms that are we would associate with chest pain. Likewise, one of the misleading terms that pops up, and there's one of the things listed on here in the group learning prescription is about angina. The term uncontrolled angina is something that needs to be jettisoned. It doesn't matter if somebody has a history of angina pectoris. If they, rest and basically sit down and don't exert themselves and take a nitroglycerin every 5 minutes, and after 3 nitroglycerin and 5, 10, 15, 20 minutes, their chest pain is still there, then that's an MI. That is going to be treated as a myocardial infarction. It's not uncontrolled angina. It's not unresolved angina or severe angina or anything like that. From our perspective, that's an MI. And so if that's part of a patient presentation, then you need to realize that that's the situation you're in and assess and treat for an MI. It's kind of similar to a TIA. If we have a patient who's showing signs and symptoms of a stroke, even if they're mild or severe, sometimes the TIA can be pretty significant, and we take them to the emergency department, technically, your symptoms and signs and symptoms, if they resolve within 24 hours, then you're having a TIA. If you have a clot or a bleed, then you're having a stroke. But if you don't have a clot or a bleed and your symptoms go away in 24 hours, then it's a TIA. Well, if the patient waited an hour, called 911, we got there, it took us 40 minutes to get the patient to the stroke center, stroke team got on him. When we left the hospital, the person was still having symptoms. We go write our patient care report and go on and run the next call. As far as we're concerned, that was a stroke patient. We documented as a stroke patient. Their symptoms didn't resolve. They still had signs of stroke, blah, blah, blah. It's a stroke. The fact that their symptoms resolved on their own 2 hours after we dropped them off at the hospital is irrelevant to us. That was a stroke patient. If the symptoms resolved before we got to the scene or while we were taking care of the patient, then that would be a TIA patient. Questions about that? So I want to talk about trauma briefly, and then we'll take a quick break. We're going to be, we're into the last hour of this whole session. On one of the EREs, 90% of the folks missed a question about distracting injuries. And that's a concept that comes up in 2 places. One is multi-system trauma, like especially penetrating trauma, but also spinal motion restriction. So in other words, if somebody was on their bicycle and got hit by a car and their tib fib is at a right angle and that nasty jagged end of the tibia is sticking out of their leg and they're screaming in pain, the fact that they have a neck injury might not be noticeable to them. Does that make sense? So your SMR assessment on that patient is not reliable because they have a distracting injury that prevents you from assessing their spine. So you may end up putting that patient in full spinal immobilization depending on your local protocols. because you can't determine whether the patient has neck pain on palpation or movement. And you shouldn't. You should just go ahead and put a collar on them and manage, you know, their spine according to your local policies and protocols. Similarly, and I've had this patient, I've told you about these kinds of patients. Patient got, you know, shot in the arm, and it's really hugely painful, and there's bleeding, and they're very upset about it. But there's reason to believe that there were other shots fired. So is there we've controlled the bleeding on this person's arm, so that's not a life-threatening injury, but is there a hole in their armpit or between their butt cheeks or on their neck or, you know, their back or somewhere else that could be life-threatening, that might lead to a pneumothorax or internal bleeding or something else that is going to kill, you know, a penetrating trauma patient. And it would be the same with stabbings, and it would be the same with blunt trauma as well. But that distracting injury might be either very painful or very gross or very disturbing, but it shouldn't prevent you from looking elsewhere for other life-threatening problems or more serious injuries. Does anybody have any questions about that? Also, I think in both classes, there was some confusion about treating an open chest wound. And that there was, on one of the EREs, there was a question 76% of the students missed about that in my group. And first off, remember that an open chest wound can be anywhere on the thorax, right? It could be the anterior chest, all the way down to the borders of the rib cage. Even though, you know, there's a certain spot where there's no more longer lung, there's liver and such. So you kind of have to be familiar with where that diaphragmatic line is. And then that could be on the lateral thorax. It could be on the posterior thorax, right? All those penetrating injuries need to have an occlusive dressing if there's because there's a possibility, a three-sided occlusive dressing, because there's a possibility of a pneumothorax. If there's significant bleeding, then you would pack that wound. But even if you were packing that wound to control the bleeding, you would still put an occlusive dressing on top of it, because you don't want air to get into the pleural cavity. So you're going to have to look at that and go, do I see external bleeding, or, you know, is it clear that there's a bleeder inside there that we need to shove some hemostatic gauze and hold pressure on? So the occlusive dressing might end up being, you know, somebody's gloved hand instead of the sterile inside of that Vaseline gauze wrapper, right? So that might be the way it has to go. And we tend to pack wounds for bleeding on places where we can't put a tourniquet on. So that might be the neck, like a jugular vein laceration, or in the shoulder or armpit, or in the groin, or a femoral artery, or especially the abdomen. We don't routinely do it, but we do it if it's clear that there is a life-threatening bleeding occurring there. Questions about any of this so far?
Could we go over a little bit about wet versus dry dressings? I always get confused about those and when to use which one.
Yeah, so the short answer is that the dressing is dry if you're dressing something that's normally external to the patient, or you're packing a wound to control bleeding. If you're packing a wound, preferably you should be using those hemostatic gauze, right? But if you don't have hemostatic gauze, then you should be using regular sterile gauze for that. Wet dressings are used when there's something that's supposed to be inside the body in a nice, warm, saline balanced environment that's nice and wet. So I'll run down from top to bottom and I think I'll get everything. If you had exposed brain and you needed to put a dressing over that because there's a spot of skull missing and there's brain that's in contact with air, you could put a non-adherent dry dressing on there, but you know, that's something that should remain moist. Your brain should stay moist. That's pretty unusual. An eyeball, an avulsed eyeball, that needs a moist dressing. So an eyeball that's sticking out of somebody's head. Tongue, I think it'd be hard to get that outside the body, but you get the idea. I think you have to go down to an abdominal evisceration, and it doesn't have to be a big load of intestines outside the body that you're going to put a wet dressing on. It could be just a little piece of bowel that's sticking out of their abdomen. That would also get a moist dressing because that tissue is not supposed to be in contact with air. It's supposed to be in that nice, warm, enclosed environment. An exposed testicle, a prolapsed uterus, prolapsed rectum. All those things should be inside the body, and if they're not, then they need a moist dressing. Does that kind of give you an idea of?
Yeah, that makes everything so much more clear.
Excellent.
Thank
I
you.
have a quick question.
Brendan, can you hold on just a sec? Because there's a point I want to make before I forget it, and that is about the occlusive dressing. So some people were putting 3-sided occlusive dressings on the border with the abdomen and the rib cage, thinking, oh, it's a diaphragm, or you know, they were thinking evisceration. The 3-sided occlusive dressing is only for the thorax. But when you put a moist dressing on like an evisceration, you're supposed to put an occlusive dressing like a big piece of, like the inside of the plastic trauma dressing wrapper, you know, over that, because you need to retain moisture and you need to retain heat. So there is an occlusive dressing. It's just different occlusive dressing than the 3-sided occlusive dressing that's supposed to go on the patient's thorax, or the 4-sided occlusive dressing if you have an open blood vessel on the neck where the bleeding is controlled and you're worried about air getting into that blood vessel, then you'd have a 4-sided occlusive dressing. Or you're trying to plug a hole in the person's trachea, then you'd have a 4-sided occlusive dressing, or you'd have somebody holding a sterile occlusive dressing onto that trachea to plug the hole so you can ventilate the patient or so the patient can breathe adequately. Okay, Brendan, your question.
I was just going to ask, for when it comes to moist dressing, should it always be like that Vaseline type gauze dressing, or if you don't have those always available, should we like soak other dry dressings in sterile saline and use those? What would we be using?
So if you're doing a moist dressing, then yes, you've got to use one of the normal sterile dressings, whether it's a burn sheet or a trauma dressing or whatever, and it needs to be moistened before you put it on the exposed organ, like the abdominal evisceration. Does that make sense? But
Yes.
the occlusive, and that's different than an occlusive dressing. The occlusive dressing should be occlusive. It's got to be plastic. It can't be paper. It can't be gauze. It can't be clothing or something like that. It's got to be plastic or foil or something that air cannot get through. That's the first thing. The second thing is it should be sterile. So typically, the only thing that we have handy in healthcare are those Vaseline gauze. And sometimes it's a plastic wrapper and sometimes it's a foil wrapper. But what you want for the occlusive dressing is the inside of that sterile foil or plastic dressing. If you had a trauma dressing that came in a plastic wrapper, you could use the inside of that plastic wrapper for a 3-sided occlusive dressing on their chest, or to cover a moist dressing somewhere else on the body, like the abdomen. But if you don't have something sterile, you should use something that's occlusive, but you should have in your trauma bag and it's usually a Vaseline gauze wrapper that you can use. Those chest seals, do you remember the Asherman chest seal? No?
No.
Okay, let me show that to you. Because I think I showed them in lab, but we didn't really talk about them because they're kind of expensive. Vaseline gauze is not very expensive, but these chest seals.
I guess my next question would be, when would we actually be using the little Vaseline gauze itself and not just like the sterile wrapper?
We don't use the Vaseline gauze in EMS typically.
Okay.
People who have like large abrasions that are healing, or, you know, like road rash or burns or, you know, second-degree burns or something along those lines. They use them in hospitals and people use them at home because covering something in Vaseline really accelerates the healing process. And it's sterile because, you know, they've got a big chunk of epidermis and part of their dermis missing. So you have to be very careful about infection in that situation. It's not like a cut on your finger that scabs over, and as long as it was cleaned out before it scabbed over or before you put the Band-Aid on it, you're good. This is something that has to remain sterile for a long period of time while it's healing. And Vaseline on healing wounds has been shown to accelerate the healing. So that's why Vaseline gauze exists. If there's another use, I can't think of it off the top of my head, but we don't use the Vaseline gauze in EMS. We use the inside of the wrapper for occlusive dressings.
Okay, thank you.
Mm-hmm. That's weird. Brennan, do you see that Asherman chest seal?
Yes, I do.
Yeah, so it's basically a defibrillator pad with a valve in the middle of it. And you put that the center of it has a little bit of gauze underneath it, and you put it onto the open wound. And again, if you have an open wound on somebody's thorax, you don't need gurgling or signs of a sucking chest wound before you put an occlusive dressing on that. You go ahead and put an occlusive dressing on it. And, you know, back in the good old days when you could go to the gun store and buy a Tech 9 and I don't know if they're still available, but they were banned for a while at one point, and a big clip of 9mm. We had the 9mm rounds. You could spray and pray and hit a lot of people with bullets in a drive-by shooting or whatever. And when I worked in EMS in the Bay Area, we carry around those little Vaseline gauze in one of the pockets of our jumpsuit, because you put 2 or 3 of them on the gunshot wounds on the person's chest, and you log roll them and go, oh, there's 2 or 3 more. And so you'd be using wrappers and cutting wrappers in half just so you could cover all the holes sometimes in a patient's body. So every hole needs to have a 3-sided occlusive dressing on it, regardless of whether the person has a pneumothorax or regardless if there are signs of a sucking chest wound. You want, if nothing else, you want to prevent a pneumothorax. You don't want to, if you can help it, you don't want to treat it when it occurs, you want to prevent it. Let's see, there's chat. Visible evisceration in the abdomen, but it's covered in dirt and mud. How do we clean the wound before providing treatment? Get out a bottle of sterile water or saline and just dump that onto the wound and wash off as much as you can. 2 things to remember about that. One is you're not going to completely clean it, but the gross decontamination, the largest amount of decontamination that you can do is going to be helpful, right? It's going to help. If there's major bleeding, then you would be washing off whatever mud you needed to address the bleeding. But if there's no major bleeding, you would rinse that off as best you can with a bottle or two of sterile water or sterile saline, and then put on your moistened dressing and then your occlusive dressing on top of that, and then putting a blanket on the patient. Those kinds of wounds, whether it's an open fracture, bone fracture, or an evisceration, or a stab wound to the chest, or whatever, all of those wounds are going to be cleaned out by a surgeon during surgery, number one. So they're going to get surgical debridement. And you can help out by reducing the amount of contamination, but you're not going to eliminate it. And the second thing is that people who have those kinds of injuries are going to get IV antibiotics when they get to the hospital. So those are the two things that are going to help prevent an infection from that kind of trauma. Did that answer your question, Keith?
Yes, thank you.
Okay, it's 12:22. I think we should just kind of push through to 1300 and finish up. Is there anything on the topics we've covered? Any questions on the topics we've covered so far? Okay. The last thing I want to talk about is obstetrics and gynecology, and maybe a little pediatrics. So on one ERE, the top topic in OB-Peds is treating a child with an airway obstruction. Again, if you're a little fuzzy on the AHA standards about full airway obstructions, then you need to review that, because that's something you have to know off the top of your head. For me, it's kind of hard because I still have about 30 years of AHA standards all kind of swimming through my head, and I have to kind of think through, okay, the current thing is the chest thrust and back blow, okay. And so you got to know those kinds of things off the top of your head. And the other thing related to that might be a partial airway obstruction, right? So if a kid is drooling and they, have a coin stuck in their esophagus or, whatever, if someone has a partial airway obstruction, that you provide oxygen to them. In the case of a child, probably blow by O2. You put them in a position of comfort. You monitor their airway, and you get either transfer care to ALS, or you take them to the most appropriate hospital, preferably an ER certified for pediatrics, or if you have a children's hospital in your area, like UC Davis or one of the children's hospitals that are specifically for pediatric patients, then you would take them to that hospital. But typically, those partial airway obstructions are rarely life-threatening, but you need to definitely need to monitor the child. Let's see. Causes of seizures, I mean, you just kind of need to look that up. They're pretty much the same as they are in adults as they are in kids. But what's different in kids is febrile seizures, right? Small children, usually infants, can have because they don't have as good control of their temperature, they can spike a temp really high very quickly, and it can cause a seizure. So review that stuff about, recognizing a febrile seizure and moderately, slowly cooling the patient. You don't want to cool them so fast that they start to shiver and generate heat. You want to just, kind of put lukewarm, water, not cold water, on their body and let it evaporate like they're sweating. You want them in a cooler environment than maybe they're in, but you don't want to blast them with the air conditioning and chill them too quickly. And then you want to monitor them, and they should be seen at the appropriate ER if if there's a possibility that it's something other than a febrile seizure. Post-delivery resuscitation care is something that's also on there. And oopsie. Vang, can you see the whiteboard?
Yes.
Thank you. So remember that inverted triangle, right? And the baby might already start with decreased O2 from the stress of childbirth, right? They're trying to be born, but they're getting squeezed through this birth canal and they can't breathe, and maybe the umbilical cord is getting a little compressed, or whatever the situation is, and they might come out not with the greatest color, or not breathing as well as they should be, or maybe with a pulse rate that's too low or something along those lines. All those things can happen. And so you may have already, when the child is delivered, you may already have a baby that's been hypoxic for a minute or 2 minutes or more. So you don't want to have a process of resuscitation that takes very long. You want to ramp up your resuscitation very quickly and not get and stay as far away from that 4 to 6 minutes of hypoxia that causes brain damage and could later lead to death if it's not reversed. You want to keep that period of hypoxia as short as possible. So you should dry, warm, stimulate that baby for maybe 20 seconds. And if they're not pinking up and breathing, and their heart rate picks up and gets up above 100, then you should move on to the next stage. Remember that the stimulation is like tapping their feet or rubbing their chest or belly or what have you. You're not spanking them. You're not, doing all those silly things they do in the movies, right? So after 20 seconds, if that doesn't work, then you move on down to blow by oxygen. You could put a mask underneath their chin and do blow by oxygen. You could use the oxygen tubing from the BVM. Just don't blow the oxygen into their eyes. Blow it past their nose and mouth, usually from above or from the side. But that blow by oxygen, regardless of their respiratory effort, a little extra oxygen might reverse that hypoxia. They get breathing faster. They get that oxygen in. Their pulse rate starts to shoot back up, and everything's good. That's probably, if you do neonatal resuscitation, that's probably the most that all of us will ever do in our career. But if that's not enough, maybe you have a baby that's premature, maybe they're opiate addicted, maybe there's a birth defect, maybe something else is going on, then you go to bag valve mask ventilation with the appropriate sized bag and the appropriate size mask, and you start ventilations. And all those things we told you about, older kids and adults, about children and adults, oh, be careful, they may have a gag reflex, or, you have to track their ventilations, or, all these other kinds of things. Neonates, you can suction them, you can BVM them, you can put an oral airway into them, but they don't usually need it. You can do whatever you need to do to manage their airway and ventilation. And they're going to be, they might be moving around, but they're not going to be, you're not going to cause problems in their airway. You need to ventilate them carefully. Not, the fastest you can ventilate a kid is 20 to maybe 30 ventilations per minute. They might breathe at 40 times a minute, but you can't do positive pressure ventilation that fast. It's just breathe, pause, pause, breathe, pause, pause, breathe, pause, pause, breathe, pause, pause, all those kinds of things. And then, if after 20 seconds of bag valve mask ventilation, that doesn't work, then you need to move on to chest compressions, right? Who can tell me what the ratio for chest compressions is on a neonate?
Three to 1.
3 to 1. 3 compressions to 1 ventilation. So it needs to be 2 people, 1 doing ventilations and 1 wrapping their hands around the baby with their fingers on the back and their thumbs on the sternum doing compressions, and you need to do 3 to 1 compressions. And that's going to continue on, and the bottom of the triangle is ALS. Right? If their pulse gets above 60 and hypoxia starts to reverse, then you might stop compressions and see how they do. But if their pulse doesn't get above 100, then you should continue resuscitation. Keep in mind, if you have a neonate, an infant, small child, some medical directors say 6 years of age below, some people say below 8 years of age. But if you call child, if you have a small child, if any of these folks are showing signs, symptoms of shock, and or their heart rate is below 60 beats per minute, then they get CPR, right? So that's your bottom line, is less than 60 beats per minute, and you're doing chest compressions. And if you're doing chest compressions, you're probably doing ventilations as well. Questions about this? Okay. One of the other things that both Professor Ayala and I had seen on our ERE group learning prescriptions is the phrase complications of a precipitous delivery. So remember that as the baby's crowning, you're kind of gently putting your hands on the head so that the baby doesn't explode out of the birth canal, tearing the perineum and causing a lot of damage. That can lead to very long-term problems that are very difficult to deal with, and surgical repair that may or may not, be successful in healing the wounds. And so when that happens outside of a hospital or a birthing center or what have you, there's not a lot that can be done in the field other than just kind of not stopping or significantly slowing down the delivery. You can't really do that, but maybe having mom pant and sort of stop pushing so that you can kind of as gently as possible get the head out of the birth canal, and just kind of keep some pressure and let it slide out. Whatever it needs to be done, but we want to reduce that tearing and any trauma caused by that as much as possible. And then also, make sure you understand about shoulder dystocia and pushing in on a shoulder and pushing down on a shoulder, either above or, the shoulder above or shoulder below, or vice versa, to get the shoulder out from behind the pelvis or the sacrum to deliver. And then, let's see, the nuchal cord is the cord around the neck that you would see when the head comes out. You'd have mom stop and pant and try and not to push while you got that cord off the baby's head, and suctioned after that as well. We've still got to suction as early as possible, mouth then nose. So review all that, because there were about 57% of the students on one of the EREs, about 12 students who got a question wrong about assisting with normal delivery. So review all that. A normal delivery can include things like shoulder dystocia and a nuchal cord and a precipitous delivery and all that kind of thing. The complications, you need to know what to do, recognize them, and need to know what to do off the top of your head, whether it's a prolapsed cord or a presenting part like a one leg or one arm, or a breech delivery where the head didn't get delivered, where the head is stuck in the pelvis. So you need to know, what to do. And in the case of the breech where the head's stuck, or the prolapse cord, you're going to be putting on those sterile gloves and reaching in there to make an airway for the breech baby and to take the pressure off the cord for the prolapse cord. And positioning the patient appropriately. The other thing that got a high percentage was supine hypotension. So remember that, the patient doesn't have to have a huge belly, from their pregnancy for that uterus to be pressing on the vena cava. It can be when they're laying down, it could be when they're sitting up. But mostly it's an issue with transporting the patient, and we need to have them in that left lateral recumbent position or recovery position, usually on their left side. That will take the pressure off of the vena cava. They also talk about, in cardiac arrest, pushing the uterus to the right to get it off the vena cava while you're doing CPR to try and improve the circulation caused by the CPR. Let's see. If the patient's on a spine board, a long backboard, or some other device, then you need to rotate. It doesn't have to be completely vertical, that would not be a good idea, but it needs to be about 30 degrees to the left, so that, and just put blankets or trauma bag or whatever under the backboard, so that they will not have that uterus pressing on their vena cava. So, oh, there it is. So if this is mom's head and that's, her nose, it's not very good. Good grief. Here's the gurney mattress. You need to have something underneath this. Again, they don't have to be completely on their left side, but you've got to have something underneath this, eyeballs, so that uterus is off the vena cava, and then you would need to make sure to strap that backboard to the gurney for safety, because that backboard could slide off or bounce around, and that would be a bad thing. It's going to be a pregnant patient who's in their second or third trimester, or if they're pregnant and they don't seem to have good cardiac output or are showing signs of shock, then make sure you get them, at least 30 degrees onto their left side. And if they're not on a spine board or some other device, then put them in basically the left-sided recovery position. Questions? Okay. So lastly, did anybody have anything from my class, anything come up about the infection control, hazmat, or emergency vehicle operations? I have a quiz almost ready. I'm going to post it today. It's the last thing you're going to do is that emergency vehicle operations quiz, but it'll be posted today. Were there any questions about any of that material?
I still need to look at the material myself.
It'll be up through the weekend. So, look at those videos and do the quizzes. There's one for infection control, one for hazardous materials, and one for emergency vehicle operations. Okay? All righty. The last thing we want to talk about is job seeking interviews and employer expectations and such. Right now with COVID-19, EMS organizations are hiring, hospitals are hiring, lots of places are hiring. You can get hired on to do, drive-through testing and stuff like that. But even without a global pandemic, there are lots of jobs where they want somebody who knows medical terminology, who knows how to deal with patients. If a patient was in crisis, they would know what to do. So there could be a job in central supply at a hospital, and they might accept somebody to work in the central supply of a hospital that had either a CNA certification or an EMT certification or an LVN license, or there might be a variety of people that they felt were qualified to work with medical supplies in a hospital or move patients around from one part of the hospital to another part of the hospital. There are clinics, there are volunteer opportunities, there are industrial sites. There's all sorts of places where EMTs work other than in an ER or at an ambulance service or at a fire department. And right now, the number of EMTs graduating and going to the workforce is a lot smaller than it has been in previous years. Plus, there's a greater need for them as well. So it's a good time, for job seeking. That having been said, there's still a fair number of EMTs out there. And if you do get a job that you really want at a good EMS organization and that has the right schedule that you want to work or has better pay or better benefits or whatever, then that job might still be competitive. Even if there's, only like 4 or 5 people applying for the job, you want to be the best candidate. So there's a few things that you need to make sure that you do. One is you have to have a resume. It doesn't matter if you've only had like one job in your life or, what have you. You need to start building a resume. And if you're not sure how to do that, then go on to ARC's website and get in touch with the Career Center. They can also help with job seeking as well, and with preparing for job interviews. You want to take this really seriously. You want to have a resume. Hopefully it has something on there like the auto extrication course that you took at another college, or the fact that you're bilingual in Russian or Spanish or Hmong or whatever, or any number of things that you think kind of make you stand out from the other candidates. You want to have an email address that doesn't sort of, that isn't a joke address, that doesn't refer to video games or sex, violence, or drugs or something along those lines. You want a very simple professional email address, and maybe you create a separate Gmail address or something like that, that just, is your first initial and your last name and a number or whatever, but something you can put on a resume that's not going to look unprofessional. When you answer your cell phone, it may be a number you don't recognize, and, so you don't answer the cell phone with "who dis," or whatever. You answer the cell phone as if it's that person calling back about the job opportunity or to schedule an interview or something along those lines. So you have to, in your personal life, kind of prepare yourself to have the professional persona and have the attitude that employers are going to look for. They look for two types of people: mature, responsible people who are going to present themselves that way throughout the whole process of being a candidate and being hired. And secondly, they're going to look for somebody who is educatable, who's trainable, who not only can understand how to absorb new skills and ideas and concepts and everything, but is willing to learn new things and do things in maybe a different way than they did at Joe Schmo Ambulance Service or Boondocks Fire Department or whatever. Questions about this so far, or comments? So if you take the whole process seriously, their employer will pick up on that. And even if you're going for an EMS job, there are typical questions that you should prepare for. And the Career Center is a great resource for this. You need to dress well, like you would for any job interview. You need to dress professionally. You need to be early. You need to confirm with them before the job interview the details, and then you need to follow up afterwards and send an email to whomever the representative was, thanking them for the interview and looking forward to hearing from them about the job and being a part of their organization. There are standard questions like, tell us about a difficult situation you had to deal with another person and how you resolved it, right? So you shouldn't lie, but you should be thinking about these kinds of questions before you get into a job interview. You should be thinking about the question of, you just got on duty and your partner reeks of alcohol. What are you going to do? Right? So you need to be thinking through those kinds of things and preparing for those kinds of questions beforehand, because many of them are pretty standard or pretty common even in EMS interviews. Likewise, you need to ask questions. If you have questions at the end of the interview, typically they'll say, do you have any questions? And you might ask questions like, I understand that this is a part-time job. How does getting shifts work at your organization? Oh, well, you put in 5 available days and you're guaranteed 2 days a month or something like that. Does that make sense? One of the questions you should ask is, what's the employee orientation process like? And if they say, oh, well, you work with a senior EMT for a couple of days, and then, you work with another EMT, for the first week, and they, and then if you have any questions, you ask your supervisor. That's a place I probably wouldn't be my first choice to work at. If you asked, what's the employee orientation process like, and they said, Well, there's 2 days of classroom work, and then you have to go to the county for a protocol exam. And then there's a week of training where we train you on all the equipment and do a skills check. And then there's a 2-day emergency vehicle operations course. And then you work with a field training officer for 2 weeks. That's the kind of place that I would want to work. Does that make sense?
Yes.
Yeah. I'll tell you what, my first EMT job, I worked for a family that owned 3 large ambulance services, and they had very good equipment, good rigs. The pay was only $3.65 an hour, but we got, that was the minimum wage at the time. But we got guaranteed 60 hours a week. We had full health, dental, vision, death and disability benefits. And I thought it was a good job. Here's my employee orientation. I showed up the first day of work after an interview. I had the interview like the day before. My first day of work was, I think it was Friday, and then my first day of work was Monday. I showed up. The manager for the ambulance service was just leaving, even though I was early for my first shift. And he handed me an oxygen wrench that had a key on it. And he said, "You're working with Joel on 387. There's uniforms down in the basement. Pick out a couple. Don't kill anybody." And he left. That was my employee orientation on my first day of my first EMT job. And do you know how I learned to do emergency vehicle operations? The first time I
was going to say by doing emergency vehicle operations.
So I'm driving down the main boulevard in the town where I was first an EMT, and I wasn't going really fast. I knew that you could only go a certain amount above the speed limit. And my partner was sitting in the passenger seat in the cab, and he was looking at the map and going, "Okay, you're going to take a left up, at Main Street or whatever, blah, blah." And we're going down the street, woo, lights and sirens. And I blow through a red light doing about 45 miles an hour. And he looks at me and goes, "What the fuck do you think you're doing?" And I'm like, oh God, that's right. We're supposed to we're slow down. He says, "No, you stop at a red light." And I'm like, "Oh, stop at okay, stop." And then you look, and then okay, all right, great, thanks. I'm sorry. I'll never do that again. That was my first emergency vehicle operations training. But at least he knew that blowing a red light was a bad idea. I'd like to say that all EMS providers have reached a level of professionalism that includes, all the kind of training and orientation that you deserve. But I don't know. I know that there are places where that's not the case. And your safety is at stake, even without a pandemic. And you should be wearing seatbelts in the back of the ambulance as much as you can. And you should be trained to operate an emergency vehicle, and you should have an infection control policies and procedures and the PPE you need, and all those kinds of things. So that's all your employer's responsibility. If you work for a non-municipal, non-public EMS provider and you drive an ambulance, you'll need an ambulance endorsement from the DMV. Other than that, the requirements are usually pretty much the same for a private provider or a nonprofit or volunteer or public provider like a fire department or public safety department or something. And it's going to include a background check that's more extensive than anything we do at the college or that you've probably been through before. The local EMS agency is going to live scan you, but your employer is still going to do a background check. They're going to do a drug screen. And if you test positive for THC, you will not get the job. So it doesn't matter that marijuana is legal. If you test positive for THC, they don't know whether you smoked a joint on spring break or were 2 weeks ago or at a party where you didn't smoke, but you passively inhaled some marijuana smoke or hash. Somebody was smoking hash or whatever. Or you were token just before you arrived for your job interview or what have you. They have no idea because the THC stays in your system and you just need to not have it in your system. So drug and alcohol testing, if you take, prescription medications like for ADHD and they're essentially amphetamines, that'll show up on your drug test, but then there's a process you go through for showing that it's a prescription medication and that you're under a doctor's care and that you have a valid prescription for that medication, etc. Let's see. And then there's going to be some kind of physical agility test. If it's strictly an EMS job, the physical agility is going to be lifting and moving and balancing and those kinds of things. And you need to have some core strength, and you need to have some lower leg or some upper leg and some upper body strength. You don't have to be a bodybuilder, but you have to have enough strength to be able to lift your end of a spine board or, flat or whatever, or walk up a hill with 60 pounds of equipment, or, twist and not, ruin your back because you have to twist in the back of the ambulance to take a patient's blood pressure or something along those lines. Those kinds of things are pretty universal. If the job includes firefighting or something else, then those requirements, are something you're going to have to investigate on your own, and are going to get tacked on to whatever the employment process is for that job. Let's see. Professor Ayala was telling us last night that both Alpha One and AMR are hiring right now. And they're probably, AMR is in many California counties, so they're probably hiring in most of their operations. You don't need to go straight onto a 911 rig in order to get good experience. I would prefer to have a partner who worked a BLS unit doing interfacility transfers, knowing that partner knows the whole process of a call, knows how to do a patient care report, knows how to talk to patients, knows how to take a blood pressure, knows how to do whatever, and then train them in the things that they need to do on a 911 call. You may work in a 911 system where, as an EMT, your job is on an ALS unit is gopher and driver for the paramedic, and you don't get a lot of experience in patient care or doing BLS skills. But there are basically two types of EMS providers: those who almost entirely do interfacility transfers or transport patients from nursing homes to ERs, who are supposed to be not critical patients, but sometimes turn out to be kind of sick, and you might have to treat them. And then there are 911 providers. And 911 is not that glamorous because, as I've mentioned before, at least 93% of all 911 calls are not life or limb threatening emergencies. So and you might work in an EMS system where you work on a BLS unit or an ALS unit and you do both interfacility transfer or IFT, and you do 911 calls. So there are mixed response systems as well. And then there are response systems where you work on a BLS ambulance and the paramedic is on a fire rescue squad in LA or comes from the hospital in a quick response vehicle in New Jersey or something like that. So again, there are different kinds of environments. Any questions about any of that before we wrap it up? Did I scare you all by yelling at you? No?
No.
Any questions about any of those things?
No, that sounds good.
Okay, so my suggestion always is that you figure out where you want to work. Is it just only Sacramento County? Would you drive to Roseville or Rockland to work, or Solano County, or Grass Valley, or Sutter Creek, or, you know, are there other places? And, you know, and go to emsa.ca.gov, the state EMS authority's website, and they have a list of all the local EMS agencies. And if you go to that local EMS agency's website, every local EMS agency is required to keep a list of all the EMS providers, whether they're non-emergency or emergency or public or private or volunteer or whatever. They're required to keep a list of all of those employers on their website. So you'll have one page that'll tell you in Yolo County, everybody who provides EMS there, and you can go to those folks' websites and find out what it would take to get a job at that ambulance service or that fire department or that volunteer organization. I don't know a lot about volunteer firefighters or who are EMTs. EMS has always been a healthcare gig for me. I have this strange compulsion to run out of burning buildings. So, you know, fire service, I've worked in fire houses before, but I don't know what that's like. I would email Professor Wolfley or Professor Anderson and maybe get some information from them. But typically what happens is volunteers are usually taken on maybe with EMT certification or maybe with firefighter 1, but they usually train you as you go. And then as they train you, then you're able to respond more often, or, you know, respond to different calls or do different things at a fire scene or do different things at a medical call, depending on what your level of training is. But I don't know too much about that. And volunteers in California typically only handle 911 calls, but you might go to some place in Nevada where, you know, there's a volunteer fire and EMS department, and some people are firefighters and some people aren't, and they're the only ambulance service for 150 miles in any direction. So if the hospital calls and says, we really need this patient taken from Fernley, Nevada to Reno or whatever, then they might do that too. Or they might call a helicopter, or who knows. So it just kind of depends on where you are.
Comment.
Yes.
Fernley, the people in the EMS system in Fernley, they would probably take him up to Lovelock before Reno.
Lovelock, yeah. Humboldt, right? I know a couple of people who work at Humboldt General Hospital, and it's a hospital-based ambulance service, and they got this huge ass burgundy rescue truck. Yeah. Heavy rescue. I can't remember what that guy's name was. He's a manager there for years. I did some research with him, but anyway, or education. I was EMS education stuff, but yeah, that's an awesome. I mean, if you want to work out in the middle of nowhere, that's an awesome organization.
I'm from Fallon. No, you don't. No, you don't want to be there.
Okay. I didn't enjoy rural Washington much either. I mean, we had to have filters on the IV tubing because if the IV fluid got too cold, we would be injecting crystals into the patient's bloodstream. So there had to be filters on it. I once on a car wreck once where they had this thing that looked like a jet engine on wheels, and they'd blow hot air into the car so that the patient wouldn't freeze to death while they were cutting the car open. I did not like being out in the middle of nowhere. And I worked in places in Washington where it was too far even to get an air ambulance. I worked one place where, as an intern, where you had to drive 45 minutes just to get to an air ambulance landing zone. And that was not a fun 45 minutes ride. All righty, so anything else? Okay, folks, so if you have other questions or what have you, you know, send me an email, leave me a voicemail letting me know that you sent an email. If there's something having to do with your certification or burning question that I can answer for you, we'd love to hear back from you. Maybe, you know, as the pandemic eases late next year, you could come back and visit the class and let us know what you're doing in EMS, or let us know how things worked out for you. We'd love to hear from any of you again, and you know, provide whatever kind of advice or support we can. Remember, you know, the taxpayers pay for you to have access to a career center and, you know, other resources, because this isn't just about, you know, getting a grade and a certificate. It's about, you know, entry level in EMS or other parts of healthcare or public safety. So, you know, avail yourself of those things, and just be safe, and take care of yourself, take care of your peers, and let us know what's going on with you in the future. Alrighty, any last things before we wrap it up? Alrighty, folks, have a good day and have a relaxing break. Take care. Bye.
Thanks, Professor Otto.
Thank you, Professor.
Thank you, Professor.
Very welcome.
Thank you, Professor.
Welcome.
Thank you.